Hi, my name is Jessica Resnick. We're going to be demonstrating the ultrasound-guided femoral vein cannulation. This is Dr. Dan Haggerty, and he's going to be performing the procedure. Frog-legging the patient's leg will move the femoral vein from the femoral artery. Traditional external landmarks for the cannulation of the femoral vein are the inguinal ligament, which is the superior border, and the femoral artery, which is the lateral border. In the inguinal canal, from lateral to medial, you have the femoral nerve, artery, and vein. For all ultrasound-guided lines, an ultrasound machine with a vascular setting and a linear high-frequency transducer is recommended. Prior to an attempt at cannulation, both the right and left femoral veins are examined by ultrasound for size and patency. Dan has selected the right femoral vein. To distinguish the femoral vein from a lymph node, the femoral vein is compressible and receives blood from the saphenous vein. Angle the probe cephalad to see the saphenous vein. You can also turn to long axis to see that the vessel runs across the entire screen from head to foot, compared to lymph nodes, which tend to be circular.
The patient has been prepped and draped in sterile fashion, and now we need to prepare the transducer. Dan is opening a sterile kit that contains a sterile sheath, which will be applied over the transducer, gel that's also sterile that will apply on the outside of the sleeve, and 2 rubber bands for securing the sleeve on the transducer. Dr. Jessica Resnick is now preparing the transducer by putting non-sterile gel on the transducer head. Dan has folded up the sleeve much like a sock, and now Jessica drops the transducer into the sleeve. Dan smooths out the sleeve and he stays sterile. He applies the rubber bands, one near the top of the transducer and one further down on the cord, to keep the transducer cord sterile. He'll smooth out the gel underneath the sleeve, and then he can apply the sterile gel to the top of the transducer. Or he can wait and do this when he's ready for the procedure. And now we can actually lay the transducer on the sterile field.
Short axis is the preferred approach to use with the femoral vein, mostly due to the limited available space between the inguinal ligament and the vein to place the transducer. In the short axis approach, the probe is perpendicular to the femoral vein so that the vein appears circular on the screen. Make sure the indicator points to the patient's right. The femoral vein should be centered on the screen. If you move the transducer to the left, the femoral vein should move to the right on the screen. If you move the transducer to the right, the femoral vein should move to the left on the screen. The center of the screen corresponds with the midpoint of the long transducer face. Dan is anesthetizing the skin with a 25-gauge lidocaine needle directly underneath the midpoint of the long face of the transducer. If you cannot see the needle tip in the near field, angle the transducer towards the needle. The lidocaine is seen being injected in the near field. This same angle approach will be used with a larger bore needle. You should see the needle tip in short axis in the near field of the screen directly over the center of the femoral vein target. If the echogenic focus representing the needle tip is not centered over the vein, either take the needle out and try again, or make a small adjustment to redirect the needle. If you have to make a large adjustment, you're better off starting over. As you advance the needle tip towards your target, you should either advance the probe proximally or rock the probe to follow the tip. When you are just above the vein, the vessel wall should collapse slightly from the pressure of the needle. At this point, you should give the needle a sharp, shallow jab to cannulate the vessel wall. Advance the needle a few millimeters further so that you are completely within the lumen of the vessel, and then decrease the angle of your needle as you advance the wire into the vein. If you are confident that you are centered, but you are not getting blood return, turn the probe so that you are long axis on the vessel and the needle. You should be able to see where the tip is and make any angle adjustments by withdrawing or advancing the needle. Capture an image of the needle in the vessel for the medical record. This completes ultrasound-guided femoral venous cannulation. The two key principles in short axis are to follow the tip of your needle into the vein. If you are well centered on the vein but still not seeing any blood return, turn to long axis to see where your needle tip is. Ultrasound guidance should decrease the number of needle sticks and improve the success of your procedure.